So, good afternoon, everybody. Um, Today, I would like to present our last case of this year. This has been a fantastic year. I believe that uh, this year has increased a lot the number of followers of our channel, Live Endoscopy channel. I would like to say thank you to everybody. I would like to say thank you also to all the medical industry that is behind us, helping us to teach other physicians to treat the GI disease through endoscopy. So the case of today is 53 years old female. I already asked 3 times to my fellows how was how old was my patient, and I already forget. So probably I am having some kind of Alzheimer. I am just joking. So the situation of this patient is that this patient had in October a pancreatic crisis that needed to stay in intensive care unit, and with a faster recovery, and was sent to home after that. But the situation of this patient is that had a second uh, pancreatic crisis, and now she have a complication of this pancreatitis. So 2 crises, and now she have this complication that is as a pseudocyst with wall of necrosis, as you can see here. So now I am in the head of the pancreas. I will freeze my image. You can see here, this is the collection that we have with this patient. This patient already have now a lot of pain, even when she's having intake of food, any kind of food. And as you can see here, this is a very well pseudocyst with wall of necrosis inside. And this patient have also gallbladder with stones, and this probably was the cause of this pancreatitis, two crises of pancreatitis, of acute pancreatitis. And the situation is that we need, in these cases, we need to treat the primary cause of this pancreatic inflammation. So you can see here the gallbladder here. So I will show you. So you have on your left, you have the gallbladder, and there is a sludge inside, and also I already saw stones inside. Okay, you can see here very well. So how we can treat this patient? Okay, first we need to treat the big problem that have this patient now is this pancreatic pseudocyst with wall of necrosis, and we need to treat that. The problem is where is this pseudocyst with wall of necrosis? This is just in the head of the pancreas, and it's the size of this is more or less 4 centimeters by 6 or 7 centimeters. Okay, and we are in the duodenal area, transbulbar area, and one of the big problem that I have is that we have in front of we have a Doppler. We have the gastroduodenal artery. You see here very well, and a lot of branch passing in front of pseudocyst. Okay, so we need to take a lot of care, because we need to drain this pseudocyst and wall of necrosis, but we need to avoid. I already had some kind of adverse events when we pass, when we perform a drainage. Overall, if we use electrocautery that we will use in this case, uh, we need to avoid these vessels, okay? So just to have a little bit more of security, when I see these kind of vessels, I try to pass first my needle and then to pass a guide wire. Why? This will help us first to go in the correct way, you know, trying to avoid the vessels, and this will help us to avoid a complication as could be bleeding. It is very important to explain to physicians from other hospital, for the hospital where this patient is, and also to the family, that these patients need to be very well followed, because even if we don't have immediately bleeding, we can have bleeding after. So we need to follow very close this patient. We need to perform a new CT scan in 15 days, and if we see that we solve the pseudocyst with wall of necrosis, probably we will don't need to perform a necrosectomy, but in 50 days we need to reevaluate if we will need a necrosectomy, or if we can leave, or we can retire the stent that will help us to drain this case, this pseudocyst. Okay, so now as I already mentioned it, I will use one needle just to fix a guide wire, and then I will use hot axios for to perform a drainage of this pseudocyst with wall of necrosis. We already have a CT scan of this patient. We know that we don't have a pseudoaneurysm of this area. It is very important because it's one of the complications of bleeding after drainage. So you need to see all the vessels, and we will start. Okay, so necesito mi guía. You can use standard needles. You can use the flex needle. I am using the standard needle from Boston Scientific. This is the this is not the acquired. This is the so I will try to have a good access, and I will try also to avoid my vessel. So the only way is this. Even in this position we have some vessels. It's worse, and we need to go a little bit far from my vessels, because even when we solve the pseudocyst. ¿Me puedes tener aquí, por favor? Alguien. Guantes, guantes. So I need to have a special position of my tip of my scope. So I am here with Dalila, my fellow from the Italiano hospital in Argentina. So she is leaving tomorrow. You can see here, I don't have any vessel here. I feel more comfortable and more sure to go inside from this area. So now I am inside. It's very I think that we are very well. Okay, give me the el hilo guía, por favor. So I will pass my guide wire inside. I don't see very well, but I don't want to change my position. I am sure that I'm inside. We need to use antibiotic prophylaxis. Empuja, Clever. Sigue. So you see, so my guide wire is inside, is moving inside the necrosis. Empuja. So I am going out, un momento, with my needle, and now my technician will help me. Empuja, sigue empujando. Pushing my guide wire inside, as you can see here. Go, sigue. And I am in a very good position now. I feel comfortable. I am sure that I am inside the pseudocyst, and I will use an Axios, but probably my Axios voy a usar el de 15. Huh? So in my country we have just Axios, hot Axios with 50 millimeters of diameter and 10 millimeter of diameter. Now it's coming, it's arriving for this year. We will show this new technology in May during a live course, and in August with the ASG live course also online. The new Axios with different kind of diameters. So from 6 millimeters, 8 millimeters, and 20 millimeters. So I think it's better in this case to use a 50 millimeter diameter hot Axios because of the quantity of wall of necrosis that is inside, and I think we will have best result with that. In our series with more than 42 cases drained, after the use of hot Axios, we diminish the number of necrosectomy that we need to perform, and probably this could be the case. So you can see very well here, my guide wire here, here is my gastroduodenal artery, and I will pass in this way, so I am going very sure to avoid the vessels and the branch of this vessel because could be catastrophic for this patient. So you will use the electrocautery. I use herb electrocautery, and we will use the AutoCAD mode FX5 with a maximum of watt of 100 watts. So I am putting my guide wire just to be followed. We don't need to use fluoroscopy. Some of you already performed this kind of drainage, but with the use of Axios and hot Axios now is not more necessary to use suelta por favor. So now, I lost my position a little bit. No, me perdiste la posición. Suelta, suelta, suelta. Si entro ahí, voy a hacer un desastre. It is very important to have the access. Ten ahí. So I am this is my guide wire. I am not perfect, but I am avoiding my vessel. So I will try to go in this way. I think I could arrive to go well. Tenme la guía. So, let me see where are my vessels. I don't see any vessel, so I am sure. Now I am very sure. Ten aquí. Así. I am inside, okay? So now I will open. You can see here. So I am very well. I am sure that I don't broke the wall outside. You can see here I am not see any kind of fluid leakage here, so I am sure that I am in very well position. My distal part of my axis of my stent is here very well, so I am so sure that I am in a correct position. There is a vessel here, you see, but I don't pass this vessel. However, with the time, it is very important to know that you can, the metal part of this axios could perform some kind of erosion in the vessel. That's why it is very important to have a control of this patient. So I already opened my luminal part of my axios inside my working channel, and now I will push because I'm sure that this is very well. So now I don't know if we can see, ¿podemos mostrar la imagen de la endoscopía, por favor? So I can see very well my axios. Okay. Ahora quiero ver la imagen del ultrasonido. So I am very well. You see here? You see here? So we have my distal part, my proximal part here inside the lumen. This is my scope, and this is a very well drainage. Very well. So we finish now. This is the first part of the treatment of this patient. Is the most important situation now. This patient will feel better in a few days. After that, it's very important to see how is the evolution of this pseudocyst with wall of necrosis, and this patient need to have a surgical resection of the gallbladder and also clean up of the biliary tract. So, but the biliary tract can wait now because the biggest problem of this patient is the pseudocyst with wall of necrosis now. So we finish. Hemos terminado. You can see the vessel here. Very well. I am very far from my vessel. Very far. Dime. In our live channel, and please come to our live endoscopy course that will be on May. There's a lot of high-level endoscopies and physicians that will stay with us. We will have live cases also, new technologies as EndoFlip and ESOFlip, BARC X, that is radiofrequency for the treatment of Barrett esophagus and and more new technologies for this course. So thank you so much and Happy New Year. Cerramos la transmisión.